Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Second Malignant Neoplasms in Cowden syndrome patients with underlying germline PTEN mutations. My name is Konstantin Stratakis, and I'm a senior investigator at the Eunice Kennedy Shriver National Institute of Child Health and Human Development in Bethesda, Maryland, in the United States. I'm a medical geneticist, and my research interest is in endocrine oncology. Enjo et al. Are reporting that in a cohort of more than 2,000 patients with an invasive cancer, 114 had the germline pathogenic mutation in PTEN. Of them, almost half, 40%, had a second malignant neoplasm, mostly breast and endometrial cancer. Although the second tumor can appear within a year from the first, the average time of appearance of a second lesion was 5 years, and in at least one case, the interval was as long as 35 years. This is a very significant observation for patients with PTEN mutations. Like patients with BRCA1 or BRCA2 mutations, who have a lifetime risk of developing breast and ovarian cancers, patients with PTEN mutations should also be followed closely after treatment of their first malignancy for the development of subsequent cancer. It is unclear at this point whether such lesions represent another primary, most likely, or resurgence of tumor cells from the first lesion, especially since some of the lesions are found at the same time. It is important to note that 22% of these patients who had breast cancer developed a second one with a 10-year cumulative risk of 29%. In other words, almost 1 out of 3. With an overall lifetime risk of breast cancer of 85% for patients with PTEN mutations, which is data published from the same group previously, and an increased prevalence of benign breast lesions, which makes imaging and other surveillance for cancer challenging in these patients, one could consider prophylactic mastectomy for at least the patients that have aggressive first tumors or a history of other neoplasms in themselves or in their family. The data suggest that this approach should be at least discussed with all patients with PTEN mutations and a history of at least one breast cancer. Another observation of the study that is worth discussing involves thyroid cancer. A number of studies have shown that male patients, in particular with thyroid cancer, have the propensity to develop other cancers, such as renal cancer, for example. In the study of Enjo et al. Of 33 patients with PTEN mutations and thyroid cancer, 30%, were seen for genetic testing after a second tumor was identified. Thus, although the overall prevalence of germline PTEN mutations among patients with thyroid cancer is less than 1%, the data from this study suggest that thyroid cancer patients that present with a second neoplasm, especially if they are male, should be considered candidates for PTEN gene testing. Along these lines, patients with PTEN mutations and no known thyroid pathology should be screened by clinical examination and potentially imaging of the thyroid gland. The good news is that according to the author's data, no patient had a second such tumor before the age of 18 years. The study by Enjo et al. Not only presents data on previously unsuspected associations, It is also significant for the new questions in cancer biology and genetics that it poses. What is it that makes these patients develop a second tumor? If late resurgence of the same tumor cells in the same organ occurs, what made these cells stay dormant for what appears to be, in some cases, many years? If the most likely scenario of a subsequent new primary tumor is the case, why does this not happen in every patient? Why do some patients develop these second and additional tumors and some do not? And why do some develop them early and others as late as decades after? As the authors comment, it is possible that other genes, possible low penetrance but tumor predisposing variants of other genes, contribute to the development of the second malignancy. Dr. Eng's group has shown in the past that as many as 6% of PTEN mutation carriers also carry apparently pathogenic variants of the succinate dehydrogenase enzyme. It is possible that other low penetrance variants, such as those in p53 or BRCA1 or BRCA2, may also be present in other patients. The present study did not have the power to report such associations and/or cumulative risks. However, this is clearly what needs to be done in the future to more accurately identify the patients that are at the greater risk for a second malignancy. Overall, the study is remarkable, both for its size and for its implications. It is a paradigm for similar cohorts of rare gene mutation carriers. It is done longitudinally by the same experienced center and physicians over many, many years with a steady methodology to identify phenotypes by experts. The extent of the disease was recorded accurately and with an intimacy with the data that is required for such analysis of genetic associations and predictive risks. One can only look forward to the expansion of the observations and the population and the studies of other genetic variants or other factors that may be contributing to the appearance of secondary neoplasms in these individuals. This data will also be useful for therapeutic decisions, as any genetic variant may dictate one or the other molecular pathway that may be involved beyond PTEN. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.